Okay, great. So we're going to get started. I thought I'd basically run through depression, panic disorders, and generalized anxiety disorders today. They came up, depression came up last time in the short answer section of the paper. And if you'd gone through it, you know, it was really straightforward. You know, it was 5-mark question. I think the average on that question was quite high. So like depression and anxiety is like, they're like asthma and COPD. They're things you've just sort of got to sort of know really well. They don't cover anxiety as much in the 4th year syllabus, but they can ask you about it in just as much detail, as far as I understand. So yeah, something that can come up in exams. Right. It's my first day using Zoom for teaching, so let's hope it all goes okay. So, okay. Is it? Yeah, perfect. Right. Hopefully this is all working fine. So yeah, we're going to review the symptoms and management for depression and anxiety disorders. So I've just collated some quotes from patient experiences. When we have particularly the longer form questions, or like, you know, the really chunky paragraphs, what you're doing with those in terms of like exam technique, you're just always trying to highlight what is the psychopathology, what is the bit that they want to see me, and why is the examiner giving me this piece of information as opposed to any other piece of information. So yeah, so that's the kind of thing you want to be able to try and understand how patients translate the symptoms that we use into their language, because often in some of the long paragraphs in the psychiatry questions, that's what you'll be doing. Okay. I'm talking too fast or anything like that, please just say. So there are 3 core symptoms for depression. So this is low mood. There is anhedonia. So when patients don't experience any pleasure or joy in things they do normally. So this can be subjective or objective. So patients are either saying things like, oh, I used to love cooking, or perhaps you have from family members, or in clinical notes, it will describe it. Patient has reduced interest in spending time with family and peers, things like that. Patients will also describe fatigue as well. And this is not tiredness related to sleep. The patients will often talk about a feeling of being exhausted all the time, or, you know, that they just can't shake this tiredness. For a diagnosis of depression, they need to have 2 of these symptoms of anhedonia, fatigue, or low mood. So they need 2 of these core symptoms. They need to have it for 2 weeks, and the symptoms shouldn't change very much throughout the day. There shouldn't really be much of a diurnal pattern, or it shouldn't be reactive to certain circumstances. So it's those tiny details that might help you prize out a depression diagnosis away from some of the other common differentials. For example, in bereavement, when people are feeling grief, there is sometimes a diurnal pattern. People who are experiencing grief can also don't tend to have anhedonia, so they can have positive experiences when they're doing things they really enjoy. Okay. So yeah, and they need to be experiencing these core symptoms almost every day, and for most of that day, most of that 24-hour period. And I have it all there. So depressed mood most of the day, for most days, for at least 2 weeks. Loss of interest and passion doing things. Reduce energy or increase fatigue. Yeah. This is the ICD-10 definition as well. There's the one in the DSM-5, which is the other psychiatry manual that people use as well. But I think this one's easy to understand. And these are the additional symptoms that patients complain about. So disruption of sleep of any type. So often people with depression complain about early morning waking. So that's waking up at 4 or 5 in the morning. I didn't like explain that, was pretty obvious. And disrupted sleep, insomnia, that's often what we're talking about when we're talking about in terms of sleep disturbance. So change in psychomotor activity. I think if you're lucky enough to have your site placement, that's one way of saying that, you will have noticed patients with depression, they really have really slow movement. So it looks like they're not moving at all. I remember a particular circumstance where I was taking a history for a patient for an hour and they barely moved at all in that whole up here. So that's what we're talking about when we're talking about psychomotor retardation. So there is no spontaneous or reduced spontaneous movements. Patients also can report agitation, but this is a subjective feeling of recklessness. So they describe this restlessness to you, but it's not like how someone who is nervous or anxious might tap their foot, or someone with mania, where physically we'll be able to recognize this restlessness. In depression, it's something a patient might describe with you. Patients might also talk about having sluggish or slow thoughts as well. This is also a feature of a change in psychomotor activity. So in terms of like reduced concentration and things like that, again, it's like just reminding yourself that it's the really obvious stuff. So reduced productivity, like in work and home life, is the kind of things that you'd be looking for in questions. I think in our question in our last paper with the depressed patient, they were having trouble at work. And one of the questions was like, how may their symptoms, impact their life at work and things like that. Suicidal thought, suicidal ideation as well. So this can range from having fleeting thoughts to having considered plans. And obviously, depending on what a patient says, it's important to consider risk assessments, and it's important to consider risk assessment in any circumstance when a patient has a mental health problem, but also in terms of what then immediately the doctor might do if they're in primary or in secondary care. These feelings of guilt as well, they can manifest generally. So patients will feel guilty about doing things or not doing things that won't necessarily be associated with the depression. There may be broader, more general feelings of guilt, but sometimes, if we look at the bottom bit where there's about severe depression, sometimes these guilt can manifest as delusions, as well. Okay. Anything else? I don't know why I've not included. So change in appetite and weight change. So like technically we're thinking about like a 5% change in body weight over 4 weeks where there's been no intention to lose weight by the patient. That's our standard definition. Patients also have a decreased libido as well. Making sure I've not missed anything. Okay, perfect. And so stupor, I should remind myself what stupor was today, I'd forgotten. Stupor is when patient is sort of a sense of dullness, where the depression is so severe, they're like barely functioning. They appear almost almost as if they are semi-conscious. So that's what sort of stupor is. Patients with severe depression, whether you can either be mood congruent or mood incongruent. So like mood congruent delusions will be ones in keeping with the depression diagnosis. So the guilty feelings. And obviously incongruent ones will be ones which don't seem like they make sense essentially for someone who has depression. Okay, moving on. So this is just the scoring system. You need to be aware. They might ask you about how you might classify depression, or what kind of depression people have. The most important bit of this obviously is for understanding then how we treat depression. Right, so we'll move on to the next slide. If people can type into the little box, or someone can unmute their mic and let everyone hear their voice as well, that'd be exciting. What is the first line treatment for mild depression? If you want to either speak or write in the little box, what is the first line treatment for mild depression? In the chat function as well. Yeah, so Tammy was like quick to the pulse. So cognitive behavioral therapy. This is like, it seems very obvious now, but like sometimes the pressure of the exam, you're doubting yourself. Mild depression, cognitive behavioral therapy has really, really good chance of success. Often in general practice, because of the delay, what you'll see your GPs, I'm sure you've seen GPs do this, is they'll also start, they may also start a course of SSRIs if it's tending towards moderate depression. If it's not quite moderate, so if it's mild to moderate, sometimes they start with SSRIs because they know there's like a 6-month waiting list. But for exam questions, first line treatment for mild depression, cognitive behavioral therapy. Perfect, right. So yeah, so in primary care, there's lots of different types of psychological therapies that you want patients to begin with. And so these are all the different alternative ways you could start, but obviously it depends on patient circumstances. So group CBT or online CBT, self-help programs, physical activity. So in terms of counseling, this is not like the 12-week courses of interpersonal therapy. These are like low-level psychological interventions. There are indications for using antidepressants. This will be SSRIs. When when people have mild depression, as they're on the screen. So yeah, if the episode persists for more than 8 weeks, if they've already had a depressive episode, or if they have another comorbid physical illness. So often when people have physical disabilities, their depression is quite a common feature. So we're more keen to start with therapies. Okay. Okay. Right. So moderate depression, we start with high intensity psychological therapies. So that's 8 to 12 sessions of CBT or interpersonal therapy. And this should be one-on-one with a trained psychologist. Okay. So yeah, in terms of, I think for the exam, make sure you have like you should be creating your own sense of formulas, the drug that you know lots about. So my the one I always go for in questions is sertraline. In terms of my first line SSRI, low side effect profile, in comparison to lots of other ones, can use in a wide range of age of patients as well. May have to consider age of patients. So only one SSRI is licensed to use in under 18s, and I've just forgotten what it is. But so yeah, so sometimes you might prefer to use certainly in younger patients, but you can use any SSRI. In questions, there's always ample opportunity to talking about side effects, checking interactions. Why does anyone know why it's so important that we see our patients after we prescribe them an SSRI in 2 weeks? I mean, there's lots of reasons, but there's one that's really important. You know what I'm getting at. Someone wants to type into the little box. So yeah, good. So there is a known risk of increased suicidality in the first few weeks of taking SSRIs. And this is mostly in the form of suicidal ideation. So yeah, patients can get worse initially. So the GP really needs to be on guard for their patients as well. Also, it's really important in terms of patient report because sometimes the side effects can be really awful, and patients stop taking them, don't take them at the right times, and things like that. Yeah, okay. Sorry, for time. Okay, so, and we just we go basically on an increasing scale of, and I think we'll notice this in all of the bits where we talk about treatments. Basically, we increase doses, we change classes, and we check we have the right diagnosis, and we check compliance. And those are sort of good principles if a drug isn't working, right? So the question is like, if the question is sort of suggesting about what would you do if you want to consider moving on to the next step of treatment. So checking the diagnosis, checking compliance. Those are sort of the things you always need to be thinking about. So anyone know what class of drug venlafaxine and mirtazapine are? Maybe someone who isn't Jamie. Anyone brave enough to answer? Okay, so these are more atypical antidepressants, which we can use. And the reason they're handy is mirtazapine is a noradrenergic class antidepressant. And because it's drowsy, it's really good for patients who have trouble sleeping. And venlafaxine is an SNRI, so it's also good for patients who have problems with anxiety as well. So yeah, so after 4 weeks, sometimes it can take 4 to 6 weeks for patients to see significant improvements. We need to check all of these things as well. Okay, right, so I'm going to move to the next slide. So yeah, so an important thing always to have in the back of our mind is secondary care referral. When can we no longer manage this patient in primary care? Again, like an exam, it's always important to remember what clinical situation the patient is in the question, because sometimes they'll be vague, or well, actually, no, they won't be vague, but sometimes like you'll be writing an answer and it's right, but actually the answer isn't right in the sense that, oh, this patient is still in primary care, or the question was set in primary care, or the question was already set and this person was under the Mental Health Act, or a sex or whatever. You just need to make sure you're mindful of that. I mean, in questions, because it's an easy way to accidentally lose marks when you know your stuff. So yeah, basically, is the patient at a significant risk within cause harm to themselves, most likely in this situation? So they need support from multiple experts or to be sanctioned under the Mental Health Act. Does anyone know what, if a psychiatrist wanted to section a patient with a first presentation of severe depression under the Mental Health Act, what section they would use? I want to type out the answer. Yeah, good. Yeah, so section 2. So section 2 covers the first 3 months of treatment, and then a patient has a tribunal and is reassessed whether it can be extended further. Okay, good. Yeah, and again, so another thing as well I wanted to just point out as well is that comorbid depression as well, we tend to be more watchful of as well. So if people have a physical health problem alongside as well, then the patient for secondary care referral. Okay. So patients have severe depression, want to be continuing all of our other treatments. We might be using different types of antidepressants, mostly things like venlafaxine and mirtazapine that I've spoken about. So they do use some tricyclics sometimes. That's not really a sort of like a full-fledged treatment. Patients have psychotic symptoms using antipsychotics, quetiapine or something like that, for example, is what they do. And obviously the scary and exciting electroconvulsive therapy. Anyone know any side effects to electroconvulsive therapy? Yeah, so patients complain of headaches. Sometimes there can be things like memory loss as well. But actually, for most patients, the side effects aren't that severe, and it has quite a good success rate as well for treating patients with life-threatening and treatment-resistant depression. This is also one of the special classes of mental health treatment. So doctors can't just decide to give someone ECT, like they can decide to give patients drugs under when they're normally sectioned. Patients have to consent as well. Okay, right, yeah, so this is remind me that I guess so. Before we move on to panic disorders, I think would people like to do a couple of exam questions that I found? That'd be useful. Right. I'm going to assume you've all said yes. So I'm going to stop sharing my screen for a second. Okay, sorry about this. Okay, share my screen again. Can everyone see the question? It is a bit wordy and long. So I'll give you like 30 seconds in there. People can write their answers, share their answers, and talk about which is. Oh. So yeah, sorry, can everyone see the question all right? Oh, right. I mean, are we okay to stop there? So yeah, people are right if you put down B. I think so. We want to be in the other reason. I guess the important thing is to consider the reason why. I mean, obviously, a CT scan is just like super inappropriate. It would be really helpful if we thought the patient had any sort of brain pathology or anything like that. But anyone know why diabetes, why the glucose or HbA1c test is one of the potential options, why they put that in there? They don't know why. Okay, I'm just going to say why, because otherwise, yeah. So it's because obviously tiredness is a common symptom in diabetes. Um, we're also trying to rule out anemia, also trying to rule out hypothyroidism. These are good go-to answers for ruling out biological causes of any what do you call it, of depression. Okay, we'll move on to the next question. So yeah, everyone can see that okay? And there's only two more in this bit, and then we'll move on to cover some panic stuff quickly and then finish with some more questions, I hope. So yeah, if you want to say the question, type out their answers once they've got them. Yeah, that's quite a wordy question. Okay. So I've got a couple of responses there. So the answer in this question is mania, right? And so there's lots of different things going on in the question, but it is this, and hopefully you can see the highlights. So these are the things, and this is again what I was talking about, picking out how people describe things and turning them into symptoms we understand. These are our symptoms. These are the reasons we come up with a diagnosis of mania. Right. Okay. So there's lots. Yeah, actually, me reading it again, I can see even more different symptoms. So people who've just started on a course of antidepressants, this can basically precede an episode of mania, because obviously the point of antidepressants is to lift your mood. So if someone has bipolar disorder, as this person clearly has, this is why using antidepressants can be quite risky, because this can obviously trigger their mood lifting too much, that ends up them having a manic episode. So that's why we get that in the first section. And then it's personality change, it's being very irritable, loud, rude, the poor sleep, the strange behavior, cooking breakfast at 4 in the morning, her being physically fidgety and restless. You'll see this in patients who are having a manic episode. They just like won't be able to sit still. And also the last bit, she's enjoying her new job as a fashion designer, when obviously we know that she's a bank clerk. So this sounds like a classic delusion of grandeur as well. Serotonin syndrome would happen over a shorter period of time. Multiple sclerosis isn't good. I guess it's sort of trying to get that as idea that the person has had a personality change or whatever, but we'd be more thinking of we're looking at a set of random lesions which are separated in location and time as well. I can't believe I just remembered that technology. Okay. Yeah, so that's why B is an inappropriate answer. And again, I think C, we're expecting, we don't really have much to lead us through a diagnosis of hypernatremia in terms of medical symptoms. On refractory depression, I think we'd want more evidence of like different efficacy of the question. Right, so we'll do this last one. It is a long like paragraph, but we'll do this and then we'll go over some anxiety stuff, and then you can all on with the rest of your lives. Oh, sorry, does anyone have any questions about any of the stuff I've just said, actually? Or just move on? Okay. Well, yeah, so if you want to answer this question, and then we can move on to the next section afterwards. So yeah, if you want a little bit longer, then people can start putting down the answers. Okay. Yeah. So yeah. So people who've answered so far, the answer is bereavement. I think sometimes picking apart grief and depression can be a difficult thing. It's like a common exam question. I mean, the obvious differentiators obviously is that the patient lost her husband, but also things like this. So this is like reactive emotions. So she's moved to tears by her memory of her husband as well. And though she's not cooking for herself, she's still doing things to look after herself. She's buying sandwiches at the local shop. And she seems to have put weight back on after clearly like a reduction in eating from the first couple of months as well. So this seems like a development of someone with normal, like the normal experience of grief as well. Okay. Right, so I'm going to talk about some anxiety things now. So let's go back to the PowerPoint. Oh, no. Amazing, my laptop started playing music. It's not a plan. Okay. So panic disorders. Okay, got excellent name from Schitt's Creek. Wonderful. So in terms of panic disorders, I just you sort of want to think about them in two sort of sort of two different ways. So we've got like generalized anxiety disorder over here, which again is general, both in comparison to panic disorders, is where there's like a specific environmental trigger or focus, and it's episodic. Someone with panic disorder has panic attacks, that's what we call them colloquially. And again, I've collated some some quotes from patient experiences here, because this is like, with panic attacks in particular, the sensations people feel, particularly if they've not had a more serious cardiac or respiratory sort of episode of acute distress or whatever, patients feel absolutely awful and are absolutely terrified about how they're feeling. So don't get caught out by thinking, oh, the patient's being very, in the description for the question, they sound like the symptoms are very severe. It's definitely not panic disorder. It's definitely not a panic attack. The way patients describe panic attacks very much can sound like other medical conditions as well. So it's really important to be able to differentiate between them. Okay. So this is a DSM-5 definition. The key thing here really is that a patient has had a single panic attack and then has spent a month or so worrying about having another panic attack. Yeah? And that's sort of the key bit of the definition. And part of that worrying about having another panic attack as well, they might do things like avoid situations that may cause another panic attack. Maybe they'll it could be exhibiting some agoraphobia. And also, it's really important, like diagnosis of exclusion, but to make sure that it's not to do with alcohol or drugs or any other medical conditions as well. But sometimes these things can be comorbid as well. Anxiety and depression are common. Substance use disorder is common as well. Sometimes people with anxiety and anxiety conditions use drugs and alcohol to self-medicate themselves to help deal with their anxiety as well. Okay, So getting on to, yeah, okay, I'll just describe it. Let's ask some question. So in terms of the actual event, often these will come out completely out of the blue for a patient, come in for a couple of minutes, and they'll have symptoms which are in all sorts of different domains. So they'll have some autonomic symptoms, some chest and abdomen symptoms, some mental symptoms, and some general symptoms. In order to qualify for diagnosis, you need to have one of these autonomic symptoms. Does anyone know examples of different autonomic arousal symptoms someone can have when they have a panic attack? So you want to write in the little chat box any of the different symptoms someone might have, or autonomic symptoms in particular. Okay, yeah, excellent. Palpitations, increased heart rate. Yeah. I just think of that Eminem song. I can't remember the one like knees weak, like your mom's spaghetti. That's how I think about it if I'm trying to recall the different symptoms of panic attacks. Okay, wonderful. So yeah, those answers that people put were all right. Good. And yeah, again, so the patterns, the distribution of panic attacks really varies from person to person. You know, someone can be having weekly panic attacks. Sometimes someone will only have one panic attack in a month or whatever. Yeah, so it's different for different patients. So yeah, palpitations, heart rate, sweating, trembling, dry mouth, those are all autonomic symptoms. So you need to be looking for one of these symptoms in a question, yeah? And particularly, stuff like trembling, shaking, dry mouth would be a really good way of arguably differentiating from some of the cardiac and respiratory conditions that might easily confuse for a panic attack because they tend to be less prevalent. Again, so we've got general symptoms, hot flushes, chills, numbness, tingling. Patients will talk about difficulty breathing, feeling of choking or a lump in their throat, which is, I think it's globus hystericus, it's like a fancy Latin name for it. It's a great name. Chest pain, discomfort, nausea, and there's also different psychological symptoms, fear of impending doom. Patients may experience derealization, and depersonalization. So derealization is to do with a change in how someone feels, like psychologically, in terms of detachment from their surroundings. So it may look like objects and shapes are changing in color or size, but the patient has insight, they're aware that that's not actually happening. Whereas depersonalization is similar in that way, where there's like an unpleasant sense or taste or just any sort of disturbed perception as a part of their body. That's what derealization, depersonalization are. They're often quite difficult sometimes for patients to talk about, but they get really worried about them because they're like, this is weird, you know, am I going crazy, doctor? That kind of thing. Okay. Great, so yeah, just listed some of the risk factors here, and you can just read it yourself. Again, the reason I put this in is that this is, again, stuff we just need to make sure that you know, so you can use this to help say, oh, is this a first episode of angina that this person is complaining about, you know, with the chest pain, short of breath, all that kind of thing, or is actually this more likely to be the first episode of a panic attack? Because sometimes someone could just present with a single panic attack history, just one episode, that's all they have to tell you. So yeah, being young, female, white, family history, other stressors, previous history of asthma, and other things. These are things you could use to differentiate away from some of the medical diagnoses. And in terms of the differentials for the psychiatric problems, you want to think about where and when. So if an examiner has told you that this only happens, that they only get this panic response in a particular setting. They've told you that for a reason. It's because they don't want you to put panic disorders. They want you to support agoraphobia, which is fear of going outside. They want you to say, oh, their panic is in response to worried about being embarrassed or some sort of embarrassing event or whatever. So they want you to lean towards social anxiety. And again, some sort of traumatic event for PTSD. And in PTSD, the kinds of traumatic events as well are quite varied. I always assumed it was like mugging or violence or that kind of thing. But lots of PTSD patients also have PTSD actually from being in ICU or having just had a serious medical event as well. Again, obviously, if there's history of substance use, that might well ward you get away from a panic disorder diagnosis. Again, if there's a specific trigger or stimulus, does it only happen when they encounter this specific thing that might lead you to a diagnosis of a specific phobia instead? I mean, chances are, like, you're not probably going to be, I think it would be new to have a question in detail about agoraphobia or specific phobia or social anxiety. Certainly could have one maybe about PTSD that came up in LOCAS last year. So yeah, those are the kind of things that will just be appearing in your questions, and you just need to be able to say, no, it's not that, no, it's not that, no, it's not that. That's sort of why you need to be aware of them. Certainly that's how I think about it. Okay. I'm going to zoom on because I've been talking too much. So aim of managing panic disorder is basically to help patients deal with their panic attacks when they happen, reducing their avoidance behavior. We want to make their panic attacks better. It's a sense like trying to teach patients to not be scared when they happen, to be informed about the condition as well. Those are sort of our important principles. Okay, so with panic disorder, we can start with CBT or SSRIs, which are licensed for panic disorders, before we can go to things like imipramine or clomipramine. I've looked at some of these for a while, as our next step. So I think, honestly, just being aware of SSRIs and CBT are the really key things for depression and all the different types of anxiety disorders. I guess sort of the difference is here is that with panic disorders, you can sort of go either or, whereas often with depression, from moderate depression, you're doing a combined therapy. There's not actually much evidence that combined therapy is as useful, has any sort of synergy when it comes to anxiety disorders. Okay. Yeah, and again, so reviewing and reassessing is really important. The main thing you want to do with your anxiety disorders is making sure you're excluding substance misuse and making sure this is the most appropriate diagnosis. Yeah, so yeah, I think that's sort of the really key thing. Because they could ask you a question of what kind of things might a doctor need to do in a review of a patient with a panic disorder or a generalized anxiety disorder. So checking for substance misuse, checking diagnosis, checking compliance, all those kind of things. Yeah, and treatment and specialist mental health services, again, it's a repeat of some of the other things that I've talked about, so I'm not going to go into any detail, except for maybe mentioning that CBT with an experienced therapist, a lot of CBT success is to do with the individual counsellor and the patient's relationship with them. Being able to do CBT in the home, considering like the overlap with agoraphobia and lots of panic disorders, can be really useful for patients. Yeah, so that's what I want to say about that. I've got a little bit because I'm conscious of time. I want to do some questions. I think questions and talking about them is helpful. So generalized anxiety disorder, this is the other type of anxiety disorder, really common comorbid with depression, with substance use as a mental health problem. And people talk about it as a free-floating anxiety. And that sort of means is that it's not related to any specific environment or any triggers. Yeah? And it needs to be prominent most days for at least 6 months. this is the DSM-5 definition. I think it's a little bit clearer to understand. So this is the one I would learn. Chronic excessive worry for 6 months causes distress or impairment, and you need 3 of these symptoms of increased mental tension, sleep disturbance, fatigue, restlessness, irritability, poor concentration. For children, children only need 1 of these symptoms to qualify for a diagnosis. It's actually 3. Okay. Again, I'm not going to go through this in much detail. So initially, when we're treating patients with, so we're following similar principles as we've done before when we have like with mild depression and with panic disorder. So it's all of this self-help, online CBT, group CBT, that you can offer patients checking for other conditions and comorbidities. Those are initial things that we need to be doing. And then we move on to, again, either using CBT or SSRIs. And you can sort of go down either path depending on patient preference and patient interest. So either 12 to 15 weeks of CBT or using a drug therapy. SSRIs, SNRIs, or atypical antidepressants are all appropriate drugs. I think certainly is first line, but any of those are appropriate drugs. So you can use escitalopram, fluoxetine, venlafaxine. Those are 3 examples that are commonly used from those different drug classes, SSRIs, SNRI, atypical antidepressants. You can either use pregabalin as an adjunct or use it as a monotherapy, like it says on the screen for those who can't tolerate those other antidepressants. And benzodiazepines, really short-term use, 2 to 4 week period, being properly monitored by the GP. Do want to be particularly cautious. I'm not sure if it's definitely contraindicated, but want to be particularly cautious for people with a history of drug and alcohol use and substance use in giving them benzodiazepines. Whilst we're doing all of those pharmacological therapies or the high-intensity psychological therapies, all these really good evidence-based adjuncts, because they like asking questions about, what are the lifestyle and non-pharmacological treatments you can use, blah, blah, blah. There are questions like that. So applied relaxation techniques, mindfulness, meditation, sleep hygiene education, non-obsessive exercise, and patient-structured and self-help are really important things. And again, in terms of for more intractable cases of anxiety, GPs should refer to secondary care, where they basically continue trying to use different drug combinations and psychological interventions as well. So yeah, that is it. Would people like to do questions? Oh, actually, before people go, it'd be really great if people could fill out some feedback. So I'm going to stop sharing my screen and just share the feedback. So it'd be really helpful if everyone could fill out a feedback form for me. That's okay. Yeah. So does anyone have any questions actually, whilst we're all sort of still here, I could answer? Okay, good. So yeah, are there any other psych topics that people would find useful as well, that I can do? So yeah, this is the link to the Survey Monkey, if it works. I don't know where. So yeah, this is the link to the psych pharmacology. Okay. Yeah, so hopefully that link, if that link doesn't work, I think this is a better one. Yeah, so if people can use the second link, I'm going to go now. So yeah, if people are able to complete that before they leave, that'd be super, super useful for me. And yeah, and I'll talk to paramedics so I could do psych pharmacology because yeah, that's out there. Yeah, so good luck for finals, everyone. Yeah, thank you.